Hey, Facebook family. How are you? All kinds of good things to talk about tonight. So you know how we do it. We're going to run some numbers first, talk about where we are. Hello, how are you? We're going to run some numbers first, and then we're going to talk about a lot of conversation around the vaccine happening. I think as folks continue to have loved ones get the vaccine, more questions are coming up. So I think this is a good opportunity tonight to talk about it. All right. All right, so let's run some numbers first. You know how we do. We talk about our global numbers, then we're going to talk about our national numbers. The good news is that when we talk about trends, we're going to talk about the fact that cases are coming down, hospitalizations are coming down, a lot of good news, but also a reminder for us not to let our guards down, all right? So let's jump into it. Let's talk about our COVID-19 numbers, all right? When we look globally, we are now over 110 million individuals globally who have dealt with COVID-19. We're almost at 110.5 million individuals across the globe who have dealt with COVID-19 in terms of being infected. In terms of global deaths, we're now a little over 2.4 million individuals who've lost their lives to COVID-related illness. When we look at the death rate, we have sat around 2%. Right now, it's at 2.1%. In terms of recovery, I always like to put the air quotes because we know that with COVID-19, both in terms of mild COVID-19 cases as well as severe, that there's still ongoing symptoms that people are experiencing even a year out. We're now at a little over 85 million individuals who have survived through COVID-19 globally. So that's where we stand there. In terms of our local numbers here in the U.S., we are now at close to 28 million individuals who have now acquired COVID-19. In terms of the number of deaths, I knew at some point within the month of February we would cross the 500,000 mark. We unfortunately have now arrived at that number. We are now at a little over 500,000 individuals here in this country who have lost their lives to COVID. The death rate associated with it has remained consistent at 1.7%. So again, lower than our global death rate that we've observed for a long time, since probably around January. We have remained pretty consistent at between 1.6 and 1.7% in terms of the percentage of people who have died compared to those who have survived through COVID-19. And one of the issues that always comes up is we think the numbers are inflated. We think that people are putting COVID-19 on the death certificate, et cetera, et cetera. And what I will tell you is that there's a likely undercount of COVID-19 related deaths, especially at the peak of the pandemic when we were dealing with issues related to hospital bed availability, transport issues in terms of EMTs, for instance, in California, being able to decide whether or not this person was viable in terms of bringing them in. And so what we do know is that there are individuals, either because of a lack of access to care or because of difficult decisions that had to be made, where they may not necessarily be counted in terms of the total number of people who have died. The counter to that is the number of people who have had COVID that we have not identified, right? We also know that the denominator, the total number of people with COVID-19, is likely significantly larger than what we're calculating, because 80% of those with COVID-19 are either asymptomatic or only mildly symptomatic. So the likelihood of us being able to identify everyone is low. And one of the things that we'll talk about a little bit later on in terms of why we feel, why collectively within the health community, we feel that these numbers are trending downward. One of the concerns now is decreased testing, and that we're starting to see a decreased rate of testing across the country because more focus has been dedicated to vaccinating vaccinating everyone all the adults in the country. And because it requires so many resources and manpower, the concern now is that are we shifting focus, right? And we can certainly walk and chew gum at the same time. So I think that we do have the capacity to be able to test and to also vaccinate. But because there has been such a push for us to get everyone vaccinated, my concern as a public health person is that we are moving away from being able to identify those who are COVID-19 positive, because while we're still trying to get more than 12% of the population vaccinated, we still need to make sure that we are allowing everyone to get a test who feels that they need to get a test, all right? So that's where we are in terms of our total numbers. Our numbers are coming down, which is a reason to definitely celebrate, but it's also a reason not to become complacent, especially with these new variants that we know are here in the country, all right? Now, as you guys know, we look at two different metrics in terms of how we are progressing as a country. The first is the number of new cases per 100,000 residents, because we want to make sure we're comparing apples to apples, right? If we look at a state like New York versus a state like Iowa with a smaller population density, we want to make sure that we have the same math fraction, right? You want to compare the same fractions. And so that's why we look at, for every 100,000 residents, how many new cases are we identifying, with the benchmark being no more than 25 new cases per 100,000 residents. And in this metric, I can report some more good news, right? So last time that we saw each other, there were 28 states in what we call the red zone, those states that had more than 25 new cases per 100,000 residents. This week, we have only 20 states in the red zone. So if you look at the map, and one of these days I'm going to figure out how I can bring like maps and all these things in, because some of us are auditory learners and some of us are visual. But if I could show you the map now compared to what it looked like in January it looked like the entire country was on fire. Everybody was in the red zone. But now what we're seeing is a good number of states now in the orange zone. We only have 20 states now in the red zone. We have 5 states in the yellow zone. So that means we have 25 states in the orange zone. So we're starting to make some significant progress. But again, I always want to make sure that I say it cautiously, because I don't want people to feel like, oh, now we can open everything up, throw our mask in the air like we're graduating from college, and go back to business as usual, when we know if we do, we will end up back where we were in January, right? It's what ended up happening. We came out of that first wave into the summer, and the numbers started to come down. And next thing you know, we were reaching record highs in January. So the good news is that in terms of the average number of daily new cases, we are making significant progress, going from 28 states in the red zone now down to 20. In terms of the states who are leading in this area, South Carolina is top in terms of the number of new cases per 100,000. Tennessee comes in second. New York is showing back up at number 3. Rhode Island has stayed in the top 5. I need Rhode Island to come learn from Vermont to figure this out, because they've stayed in the top 5 over the past about month, maybe month and a half. And then New Jersey has actually started to creep up in terms of their number of new cases. And it's interesting that New York has crept up in terms of the new cases per 100,000 when Governor Cuomo is now starting to have conversations about reopening New York. Last week, he had talked about opening up restaurants at 10% capacity. Now there's some conversations about increasing it to 25% capacity. We have to be very, very mindful of the impact of these variants and the fact that they can cause twice as much infection as the original COVID-19 strain. So we want to be cautiously optimistic, but at the same time, we have to be very, very vigilant and diligent in terms of how we approach this, all right? So we want to make sure that we're doing it in the right way. There are now, I believe, 5 states that are currently in the yellow zone. Hawaii was sitting by itself for a long time, but now there are at least 5 states that are now in the yellow zone, meaning that they have significant, they're close to the Hawaii is actually close to the green zone. They're at 3.8 new cases per 100,000 residents. And between Hawaii, North Dakota, which before was the top country or top state in the country in terms of COVID-19 cases back in November and December, they are now in the lower part at less than 5 new cases per 100,000 residents. Oregon, Washington, and Wyoming top out the 5 states doing the best in terms of the average number of new cases. So strong work, Midwest. We're definitely moving in the right direction. In terms of the percent positive, which is the second metric that we look at, the goal is to have of all the tests being done, less than 5% of all testing being done, that will be positive. The other part of good news is that last week, 31 states were higher than 5% positive. Now we're at 24 states being greater than 5% positive. So again, we're moving in the right direction. And the interesting thing is last week, we still had states like at 30% of their tests coming back positive. Now the highest was 28%, I believe. I don't want to misspeak. In Idaho, their percent positive was 28.2. The states that top out the number of percent positives in terms of being greater than 5%, these states range between about 14% to 28% in Idaho. The highest percent positive was Idaho, followed by South Dakota, Kansas, Iowa, and Alabama. And Alabama has run in the 20% range for the past several months. But the fact that we're seeing such decrease in terms of percent positive testing, so even in the face of us reducing the total amount of testing, one of the great things in looking at the percent positive is that no matter how reduced the testing is, right, we are still looking at that percentage to see of the testing being done, how much of that is positive. And we're certainly moving in the right direction. The other area that we look at is trends. What are we looking at in terms of the total number of cases across the country? What are we looking at in terms of total number of deaths and that average number of people who die per day? And then the third metric that we look at is hospitalizations in terms of access to care. Because if you remember, even at the beginning of this pandemic, one of the reasons why these stay-at-home orders were put in place was so as not to overwhelm the healthcare system. And what we started to see in the month of January was a true overwhelming of the healthcare system, where gift shops were being converted into patient care spaces. EMTs were given the right to make the decision as to who was going to be transported and really who was going to live or die. So what we definitely want to take a look at is what's going on in terms of hospitalizations. When it comes to cases, the excellent news is that we are now down to an average of a little over 64,000 new cases per day. That's huge in terms of where we have been. If you guys remember, back in around January 13th, we were topping out at close to 300,000 new cases a day. We had reached, I believe it was 289,000 new cases a day. So the fact that we are now down to 64,000 new cases is excellent. But again, I'll talk to you a little bit about what are sort of the speculations as to why that number is declining. I think part of it is it's colder. We're over the holiday hump. People are staying in their homes. Like a lot of us on the East Coast are anticipating some really bad snowstorms. My heart goes out to my brothers and sisters out in Texas and in Louisiana. They're dealing with snowstorms, power outages, water outages, winters like we've not seen before. And I think a lot of that has to do with global warming, but that's a whole nother Facebook Live, right? But one of the benefits in all of this bad weather is that we're not going out. We're not necessarily socializing as much as we would once winter breaks and the spring shows up next month. So what we want to do is celebrate the fact that our numbers are coming down, but also be mindful of some of the reasons why that is taking place. So one is because I think a lot of us are more diligent about wearing our masks. Two, we're staying at home more because it's so cold. Three, because a lot more people are going out and getting vaccinated. We'll talk about those numbers in a little bit, but the fact that we have reached over 10% of the population getting at least one vaccine and close to 5% of the population getting both doses, that's definitely a move in the right direction in terms of reducing our numbers. We are down 43% in terms of new cases from just 2 weeks ago. But as I mentioned earlier, the biggest concern is part of the reduction in cases a reflection of the reduction in testing? And what we do know from some of the data collection organizations, so Johns Hopkins is one of the premier data collection institutions. And one of the things that they have reported looking state to state is a significant decrease in terms of the total number of tests being done across the country. So clearly, if you reduce the number of tests being done, you're going to reduce the number of number of cases being reported. So we have to keep a close eye on that in terms of making sure that we continue to monitor for COVID by way of testing, especially as we continue conversations about bringing our little ones and our big ones back to school, all right? The other area that we have to take a look at is, as I mentioned before, hospitalizations. We have reduced hospitalizations by close to 30%. We are averaging around close to 77,000 individuals who are currently hospitalized compared to just last week when we had, we are now at 64,000 individuals who are hospitalized. Last week, we were at a little close to 77,000 individuals who were hospitalized. So we've reduced hospitalizations by over 10,000 in just this past week, reducing hospitalizations by close to 30%. And then the other sort of telltale sign of the fact that we're starting to come on the other side of this curve is the number of people who are dying from COVID-19. And I'm happy to report this. I feel like I'm giving a praise report, is that the average number of people who are now dying from COVID-19 we're now at 1,700. I repeat, 1,700 individuals who reported between yesterday and today that we lost due to COVID-19. That's a reduction of almost 50% compared to last week. If you guys were with me last week, we were averaging just shy of 3,000 individuals per day. We are now down to 1,700 people who are losing their lives every day to COVID. It's still way more than we want, but it's certainly much better than we have been. That means that there is more space in hospitals for us to be able to provide excellent care. It means that prayerfully more people are staying at home. Therefore, those who are at higher risk for death are seniors. Our folks who have chronic diseases have heeded the warnings to make sure that they are protected, and we are definitely moving in the right direction. But all of this will go to where in a handbasket if we start to get comfortable, if we start to slip up, and assume that of the 12% of the population that's gotten vaccinated, that the other 88% of us can just go out and not do what we need to do until we add to that percentage in terms of vaccines, all right? So I wanted to make sure that I shared all of that good news with you in terms of cases, hospitalizations, and death. So I think that we can definitely breathe a sigh of relief that we're making it around the bend in terms of improvements, but it's up to each and every one of us, right, to make sure that we move in this right direction. And not just us individually, but also us collectively in terms of our elected officials. If based on cases coming down, deaths coming down, and hospitalization rates decreasing, we hit the accelerator like we did back in April. If we hit the accelerator in terms of opening everything back up immediately without the proper provisions being in place in terms of the number of people who need to be vaccinated, in terms of the sites for people to get tested, in terms of people being able to wear their mask and it not being a political statement that you don't, right? And also in terms of our government monitoring mutations, if we don't pay attention to all of those things and then just push for restaurants to be open, hair salons, gyms, concert venues, weddings, and all those things, not only will we see a reverse of our progress, but it will be even worse because we have these variants that are now doubling the infection rate. And as I transition into a conversation about transmission and the current concerns about these new variants, we now have data coming out, which Ms. Worthy had mentioned earlier, that there is a concern about increased risk of death with the UK variant. The Prime Minister of the United Kingdom about a month ago had mentioned concern about the B117 variant, the UK variant, being more deadly. Well, we now have some preliminary evidence to that fact, that it is somewhere between 30 to 70% more deadly than the original COVID-19 strains of virus. They looked at patients who were hospitalized across the United Kingdom to determine the risk of death based on the variant or the strain of COVID-19 that the patient was infected with. And based on this information, depending on the hospital in which the patient was admitted, there was between a 30 to 70% increased risk of death compared to the original COVID-19 strains. So that's the reason. More infectious, at least we know all three of these variants, the Brazilian, the South African, and the UK variants. We know all three of them to be more virulent in terms of being able to cause infection. But now there is evidence coming out that at least the UK variant has a higher risk of death associated with it. The organization that presented this data is the New and Emerging Respiratory Virus Threats Advisory Group. It's the group within the UK that is, one, monitoring for mutations, and two, monitoring for the impact that these mutations have on the risk of infection and the risk of death. The other part of good news is that the the vaccine companies, Pfizer, Moderna, AstraZeneca, and Johnson & Johnson are also monitoring the efficacy of the vaccines in the face of these new variants. But I wanted to make sure that I mentioned to you that there is now data to support what the Prime Minister reported out even a month ago, which is yet another reason for us to maintain our vigilance as it relates to COVID-19. Not for us to be panicked and scared, but to do what we've collectively done since this pandemic began, which is to protect each other by wearing a mask, double layered, with a filter in between or an N95, making sure that we stay home if we feel ill, accessing testing, making sure our hands are washed, all of those things, all right? So I want to pause there for a second to see if there are any questions or concerns that you have about that information, all right? Oh, you're so welcome, my love. It's my pleasure. You know, certainly when we hear information like the new variants being deadlier or the vaccines not working with these new variants, it's important to peel back the layers, to go to trusted sources of information so that we know, is what we're hearing true? Is it speculation? As part of the challenge in the current media space Everyone wants the story. Everyone wants the retweet, the repost. And sometimes our media organizations will jump the gun in terms of reporting some of this stuff out, which is why it's important to go back to independent sources, not just going to the news itself, but looking at, if you read a news report, clicking on the article that they reference to truly understand how did they report it? Is their tagline that they put the story out with really reflective of what the data demonstrated, or is it inflated so that you will click on the story, open it, and then share it? And what my goal always is to peel back those layers and figure out, okay, what was the source of this data? What is an independent institution reporting out about some of these things that we hear about in the lay public? And it's my honor and my pleasure to be able to bring that information to you. And I certainly welcome you guys to send me any stories, any questions that you have, so that we have the space to be able to discuss it. In terms of the variants, I also want to make sure that I reiterate, as of right now, based on information out of Moderna and Pfizer, the vaccine that they have out being administered now is still effective in terms of creating an immune response sufficient to protect us against, and we'll talk about what the vaccine is designed to do, but it's designed to do one of three things: protect us from getting COVID, protect us from getting really sick from COVID, and protect us from dying from COVID. Thus far, based on these current mutations, the vaccine is still effective in terms of doing that. And we will continue to monitor that as time progresses, and if and when more mutations happen. We know that when a virus replicates, it mutates. So the slower we can, the slower we cause the spread of COVID-19, the less cases we have, the more we can get ahead of mutations, and the more protected this current vaccine will be. So that's part of sort of the method behind the madness in terms of us who have not yet gotten the vaccine to still practice those basic public health measures, all right? In terms of the vaccine, the good news is that we are now, as I mentioned, at over 10% of our population now receiving at least one dose. There are, as of today, 40.3 million people who have gotten a single dose of either the Moderna or the Pfizer vaccine. That puts us at, I believe, a little over 12% of us who've gotten vaccinated. In terms of full dosing, we now have, I believe it's 15.5 million people who have gotten both doses. So we're a little shy of 5% of the population getting full dose. And as you guys know, I'm very transparent in terms of my process. And I let you guys know, I posted a video sort of talking about how I'm going through the process of deciding on when I get the vaccine, not if, but when. My target is 10%, when 10% of our population here in this country has received both doses. And I do a comparative analysis of side effect profiles in the vaccinated population versus the general population. You will see me rolling my sleeves up. I would anticipate that, given how quickly we've been able to amp up vaccine delivery across the country, I imagine that within the middle to end of March, we will reach that 10% threshold in terms of people getting both doses. And as you guys have heard me mention before, in any study, any scientific study, a decent sample size is around 10%. So that's where I got that number for any of you who may be wondering, well, where should you get 10% from? In a standard study, 10% of your population is a good representation of the population. In terms of side effect profile, I don't have any real health issues other than asthma. So I'm looking at otherwise healthy people who have been vaccinated. What are the issues that they're dealing with in terms of this vaccine, so that when patients, parents, loved ones, family members, community members say, well, doc, how did you decide on this vaccine, that I can speak to data and science as opposed to just telling you to go get it, right? That's how I practice medicine, is to be able to make informed decisions based on what it says in the data. So that's where I'm coming from in terms of how I'm approaching the vaccine, all right? So, oh my goodness, someone actually, you said COVID is such a metamorphosis, right? It's almost as tricky as HIV. Luckily, we haven't seen it metamorphosize in the same way that HIV does, right? So we know with HIV, if you give HIV just one medication, it can mutate within like days, right? You can take a patient, give them one antiretroviral, which we don't do, but we give them one antiretroviral, and then we do genetic testing of that HIV virus just a couple of days later. You can observe genetic changes within days because the virus is just so brilliant. The interesting thing with COVID, I think, with it is that it's just because it's replicating so much. It's an imperfect process. So the more COVID replicates, the more it's going to mutate. And because of that, we're going to see these variants. The good news is that when it comes to treatments, especially like dexamethasone, the one treatment that we have been able to identify that not only decreases COVID-19 symptom severity, but dexamethasone also decreases risk of COVID-19 related death, it's still effective. We haven't seen any studies coming out to demonstrate that dexamethasone isn't still doing what it does to decrease the high levels of inflammation that COVID-19 causes. But it's absolutely, especially when it comes to the systems that COVID-19 impacts, right? So literally from the crown of your head to the soles of your feet, from your brain to your toes, COVID-19 can impact your health. That for me is the scariest thing. The mutations are unnerving, but that's not surprising. What's surprising to me is the spectrum of symptoms that COVID-19 can manifest, and it goes to that multi-inflammatory, multi-system inflammatory syndrome that someone brought up. Literally, particularly for children, for COVID-19 to be able to impact from their eyes all the way down to their toes, right? That's why it's called multi-system, right? And we're not just seeing this in pediatrics. We're starting to see this more and more in young adults, in the teen population, which is another reason for us to have very real conversations about reopening middle and high schools, to make sure that our children have the provisions, our teachers have the provisions necessary to protect our little ones from COVID and then from some of these complications that we see as it relates to multi-system inflammatory syndrome, all right? So let's talk a little bit more about the vaccine. We talked about the numbers and the good news about us reaching more than 10% receiving a single dose and almost 5% now receiving double dose. I want to spend a little bit of time talking about what this vaccine does, right? So there have been several reports where individuals have received both doses of COVID-19 and still tested positive for the virus. And what I want to spend a little bit of time talking about is why that is not surprising. So, with both Pfizer and Moderna, the two study outcomes that they looked at, the two outcomes were, does the vaccine protect against severe infection? And does the vaccine protect against death? What they did not do was test both the placebo population and the vaccinated population for asymptomatic COVID-19 infection. What they did was looked at of the between 34,000 and 43,000 individuals within this study, around 170 people were exposed to and then developed COVID-19. So I want to make sure that you guys understand it wasn't that they exposed everybody to COVID and then looked to see who got it and who didn't. They're starting to work on that now in order to answer that question. But both vaccine studies they took a bunch of people, vaccinated nearly half, and everyone else got the placebo. And then they monitored them to see who got COVID. And once they identified who got COVID, they then unblinded that person. They revealed whether or not this person got the vaccine or if they got the placebo. So it was of the 170 people that got COVID, not the 43,000 people in the study. Only the 170 people who living their lives acquired COVID-19. Did they look at that 170 member group that got it? Who got the vaccine and who didn't? Of those 170 people within the 43,000 population that got it, 8 people who were vaccinated were in that 170 member group. That's where that 95% comes from. So what that means is that of the 170 people who got COVID-19 within this 43,000 member study, only 5% of that 170 people were vaccinated and ended up with COVID. That's where that 95% number comes from. So if only 5% of the 170 were individuals who got the vaccine, they can say that it was 95% effective in terms of those who were exposed and had placebo. So I just want to make sure you guys understand, it wasn't that everybody got exposed and all of those who got the COVID-19 vaccine, 95% of them didn't get sick. It was of the 170 individuals who got COVID, only 5% of those individuals were individuals who got the vaccine. What that means is we don't know how well these vaccines completely prevent someone from acquiring the COVID-19 virus. It's the same thing with the flu. The goal is, if you get the flu vaccine, hopefully you don't get it, but the goal is that if you get the flu vaccine, it will minimize your risk of developing significant symptoms. And we do not know, of the individuals who received the vaccine, how many of those individuals ended up being asymptomatic and were able to or were not able to spread COVID. So when we see individuals who've been vaccinated with both doses and it's been more than 2 weeks, number one, the vaccine is not, the goal of it ultimately isn't simply to prevent you from getting COVID, but to prevent you from getting really sick and dying from it. Ultimately, we want to know, does the vaccine also prevent you from getting it and then spreading it? All right, I hope that makes it a little bit more clear. What they are now doing is allowing people who were vaccinated to be willingly exposed to COVID to see how well it does prevent you from acquiring the COVID-19 infection, number one. And then two, if you end up acquiring the COVID-19 infection in the face of being vaccinated, does an asymptomatic infection allow you to then spread the virus? Which is one of the reasons why we still say, even if you get vaccinated, you should still wear a mask, at least for right now. It will likely change. The CDC will likely change those recommendations once we reach the 70% mark. Once we reach herd immunity, where there's so little COVID-19 being transmitted from person to person that it significantly minimizes the risk of us being exposed and then spreading the virus to the 30% of the individuals who've chosen not to get vaccinated, all right? So I hope that helps. Let me know if you have any questions. I plan on making this its own separate video. My goal is to be able to use some visuals because, again, I'm very much a visual learner. And so when I see groups and categories, it helps me to see it better than when I hear it. So those of you who are also visual and not auditory learners, hold tight, I have something for you. I'm going to make sure that I can post this in a very visual way so that you guys can see it as well. But I did not want to not explain it tonight because you're going to continue. As more people get vaccinated, you will likely hear in mainstream media more stories about people who were vaccinated still getting COVID in some capacity, more often than not, just testing positive or only having mild symptoms. And I don't want those of you who are still thinking through whether or not you get the vaccine to say, see, why am I even getting this vaccine if I'm still going to test COVID positive? The reason why you still should consider the vaccine is the two endpoints that the studies focused on: minimizing severe symptoms and minimizing our risk of hospitalization and then dying from COVID. And I know for myself, I want to minimize the symptoms, which is one of the reasons I get the flu shot. There have been years where I've gotten the flu shot and I still got the flu, but guess what? It was only a day or two of being sick as opposed to 2 weeks when I didn't get the flu shot before. So there's sort of the method to the madness behind why some individuals will still either test positive for COVID or have mild COVID-19 symptoms. The other two reasons why individuals may still develop COVID even after getting the vaccine is, one, because they may be immunocompromised in some way, meaning their bodies did not mount an appropriate immune response. It could be that they were already immunosuppressed or immunocompromised because of an underlying health condition. Sometimes in terms of how we eat can impact our immune response. One of the things that I always recommend, especially right before you get vaccinated, is that you not take ibuprofen or Tylenol, because those both can mute the immune response to an immunization. I tell parents all the time as a pediatrician, don't give the baby or your big kid Tylenol or ibuprofen before they get the shot. If they develop muscle pain or fever afterwards, they can do it, but certainly you don't want to do it before, because it can impair your body's immune response. So those are some of the reasons why we still see a COVID-19 infection even in the face of individuals who have been vaccinated after that 2-week period after the second vaccine. Now, if they get COVID-19 in between vaccine 1 and vaccine 2, we already know that the body has to reach a certain level of immune response for our bodies to be able to fight off COVID and not then progress to the infection, or at least to a severe form of the infection. But your body does not necessarily mount a sufficient response after the first dose, at least for Pfizer and Moderna, which is why they recommend that second dose, so that the immune response picks back up and remains steady for your body to be able to monitor for COVID and then fight it off when it shows up. All right. So I want to pause there for a minute and make sure that I give space for any questions. All right. I hope that was helpful. But like I said before, I think a visual will definitely help as well. In terms of the mutant strains, we talked about the fact that Moderna, Pfizer, AstraZeneca, and Johnson & Johnson, thankfully, are staying ahead of the curve in terms of continuously monitoring the vaccine's ability to still facilitate an immune response to even these new variants. The other bit of good news, and I think it's not just a bit of good news, it's a huge chunk of good news. The CDC has now committed $200 million to mutant tracing, right? They are tracking the virus to monitor for mutations. Finally, the U.S. for the past year has ranked number 43 in terms of developed countries monitoring for mutations. And here in this country, it's been really state to state. It's very state dependent as to how well we monitor for these variant strains. The CDC has now committed, they put their money where their mouths are. They've committed $200 million to monitoring for mutations, which is going to serve us so well as we move into the spring and go into whatever may be the next season of COVID. The other reason why there's some speculation about COVID-19 cases coming down is that, as we've talked about early in the pandemic, is that there may be some seasonality to COVID-19. In the same way we see seasonality when it comes to the flu virus, right? And what I mean by seasonality is that there's a season of flu that usually starts around end of September, beginning of October, and flu season lasts until around the middle of March. Viruses are very sensitive to temperature changes. Anything that changes their environment, temperature, humidity, etc., can weaken a virus's ability to live. So now there's some speculation that there will be some seasonality to COVID-19 where it mirrors the pattern of influenza in terms of its sensitivity to temperature and other climate changes. We didn't really see that last year, but that was because we were not able to get ahead of the curve in terms of the number of new cases. With better treatments, with more of us masking up, and now with the vaccine in place, hopefully we'll be able to facilitate seasonality when it comes to COVID-19, all right? In terms of kids, I want to spend a little bit of time talking about our little ones as it relates to COVID-19, especially when it comes to the vaccine. So the good news is that Moderna and Pfizer have been able to really get kids enrolled in the vaccine program. Whether you are in support of little ones getting the vaccine or not, one of the things that's going to bring children back to school and keep them in school and protecting themselves and their teachers will likely be a vaccine, right? Because we know that the teachers will likely get it. I know here in Maryland, there's been a huge push for our educators and our administrators to have access to the vaccine. Although our children have not been disproportionately impacted by COVID in the same way that adults have, we have, as a result of just increased numbers, seen more children dealing with COVID-19. We've seen more multi-system inflammatory syndrome cases within the past several months in our pediatric population. Older children more so than younger. Teenagers are actually at higher risk of developing COVID-19 complications. In the same way that grown-ups, the older you are, the more severe the infection. Data is now demonstrating the same thing for children. So 10 years old has been sort of the benchmark for children older than 10. They are demonstrating more severe symptoms than their younger counterparts, which is one of the reasons why both Moderna and Pfizer are focusing on the older population. For Moderna, the vaccine right now cuts off at 18. For Pfizer, it cuts off at 16. So both Moderna and Pfizer are focusing on the 12 to 17 and the 12 to 16-year-old populations, with studies happening right now. They're anticipating, as we talked about last week, that they're going to start focusing on children between the ages of 6 and 12 as sort of the phase 3 part B in terms of getting younger children vaccinated. We still have not yet considered whether or not we're going to vaccinate the babies. Usually for little ones, for instance, for the flu vaccine, little ones can get a flu vaccine as early as the age of 6 months old. The reason why we do that is that the pediatric population is disproportionately impacted by influenza, and the younger a child is, the more significant risk there is of bad outcomes from influenza. So we're looking at the data to determine whether or not little ones between the ages of 6 months to 2 years of age and from 2 years to 6 years of age are at sufficient risk for resources to be dedicated this year to a COVID-19 vaccine. But I can almost guarantee you that at some point in time, we will see a vaccine for little ones as young as 6 months of age. And as a pediatrician and as a mommy, I will be keeping a very close eye on these developments and really sharing that information with you. One of the things that I also want to talk about in terms of our pediatric population is the return to school, right? So just recently here in my county, they have talked about us going back to school in April. And when I announced it to my little one, she was so excited and she was so happy. The good news is that the CDC has pushed out very clear recommendations, right? In terms of getting our kids back to school. It's making sure that they can maintain social distancing of 6 feet, making sure that there's a mask mandate in place, making sure that there's proper ventilation in the school systems, making sure that teachers can get vaccinated, making sure that teachers and students have access to testing and hopefully rapid testing, making sure that there's good contact tracing policies, but also having metrics in terms of when things have to shut down and be reverted back to virtual spaces. The challenge with the current metrics that they're pushing out in terms of the number of new cases, average number of new cases per 100,000, in terms of the number of percent positives, is that only 5% of the country right now meets those metrics. And the question is whether or not the other 95% of the country will be able to reach those metrics that we talk about every week between now and April. And will there be this rush, right? Because there's the balance between our children's risk of COVID, especially if teachers get vaccinated, and we can put all these measures in place. States have done it. There are states in the union that have had their children in school since the beginning of the school year, and they've seen no bump up in terms of cases. So clearly it can be done, but it has to be resourced. Monies have to be put in place for all schools in an equitable way to have all the provisions in place for all of our little ones collectively to be able to go back to school. And if that is the case, my little one goes to school out here in Maryland. If the provisions are in place, and I feel confident that they are in place, I have to balance my little one's risk of COVID, right, with her risk in terms of her psychosocial development, her academic achievement. And I'm not just talking for my little one, because like I used to be an elementary school teacher before I went to medical school. So when she has challenges with multiplication or handwriting or whatever the case may be, one, I'm an entrepreneur and I get to dictate what my schedule looks like. And so again, I always like to admit when I sit in a position of entitlement, I'm privileged where I get to work from home and see patients virtually for the most part. And even when I see them in person, I have my own space where my daughter's secluded. I've got all my air purifiers on and I can see patients in person and still be able to serve as one of her virtual instructors. Not all of us have that same privilege. And so for all of us collectively to be able to comfortably send our children to school, we have to make sure that universally across the board in an equitable fashion, every school where we are considering bringing our children back into school meet the CDC's criteria, and that we do not rush it, but that we are cautious in it, balancing between the risk of COVID exposure with the risk of academic widening of the academic achievement gap, decrease psychosocial development, and the emotional toll that this is having on our children. I shared a post. I was pretty transparent. I'm sure my little one, when she's older, she's going to be mad at me for being so transparent. But my little one, usually we celebrate Mardi Gras in a huge way. Either we have family and friends come over for a big Mardi Gras party, we'll go to a restaurant that has Southern cuisine and we'll celebrate, or we'll be back at home in Louisiana. But because of COVID, we couldn't have a party, we couldn't go out, and we weren't getting on a plane to go home. She was devastated. And as much as I tried to make up for it, I brought in, Louisiana food. I had some music playing. I pulled out the parasols. I tried to pull out all the stops. It didn't make a difference. It didn't make a difference. She boo-hooed her little eyes out. And so the same thing with school. She was upset today because she said it wasn't the same. They got to meet an author of a book. And she said it just wasn't the same because I had so many questions. And on the computer, my teacher can't see me. She can't see that I have my hand up, but if I was in class, she would have seen me and I would have been able to ask my question. And so our little ones are going through it, y'all. They are feeling the pain of being virtual. And so we, as parents, as caregivers, as educators and advocates of our little ones, we really have to balance all of that out, with balancing out the concerns of our teachers and our administrators. So as we get ready to make these decisions, either in the spring, if we all get some act right? If we all do what we're supposed to do and mask up, social distance, act like COVID is all up in the air, and not get comfortable, not let our guard down because our numbers are coming down. We have to remain vigilant so that we can cross this threshold and be able to comfortably send our kids back to school, comfortably be able to interact with each other. Like, that's the end game. Not to rush this process, but to take our time in getting there so that we don't have to revert back and start shutting things back down. All right? So those are the updates for the week. I will be back here this time next week to provide more updates. Until then, in the meantime, between time, do not hesitate to tag me on stuff on Facebook so that I can provide immediate response or as fast as I can, but also continue to send those articles to me, send those questions to me so that I can be a source of information and facts as much as I can. And I will tell you in a minute when I don't know, but I certainly will work hard to get the answer for you guys. As Miss Worthy always does, she put my website up on our Facebook Live. You can reach out to me. It isn't just to schedule an appointment, but it also gives you a way to stay connected to me through all the social media platforms as well as direct engagement. All right. I love you guys. I miss you guys so much. I cannot wait for us to be able to spend time in person together, loving on each other without risk of spreading the cootie. All right. Until then, I will see you guys next Wednesday. I love you. Dr. Yola out.